So please welcome Dr. Miranda Harvie. Okay, thank you for inviting me to talk today, Lisa. I'm honoured to be the warm-up act. Now this is a huge topic and I can't possibly hope to teach you everything in such a short amount of time. So I've brought you a selection of cases that I hope you will find worthy. Today has quite a few cases that either I or my dear colleagues have found, shall we say, overly challenging. But with careful reflection and learning, a similar case may not be missed next time. So could you please load into your smartphones this little link here. I just need to declare that I have no conflicts of interest presenting this lecture. I have raided a couple of internet sites. They're labelled as we go. The radiology assistant, I was too afraid to use the Radiopedia site with the eminent, it will come up throughout the talk will be the link. So I have acknowledged those as we go through. So here's the link, http://etc.ch/8XBZ. So it's going to be just a little bit of a fiddle to get this working on one system without a separate beamer. So we'll see how we go. So let's try the first question. So it's going to take me prompting from the bottom tab. So as we go through the cases, I'll let you have a look at the case before I hit the voting button. So now if I hit the voting button, I need you to tell me if you are originally from Wales. That's our warm-up question. Let me just go back to... My poll has got ahead of itself. We'll just reset that. So, have you all voted? And that's how it should work. Please, some of you have got a sense of humour. So these cases that I'm going to show you are not easy cases. There will be a get out of jail free option, and a lot of people on some of these cases would go straight to CT. So I don't expect you to get everything right, and if you get it right, some of you will be getting it right because you're guessing, and that's fine too. I just want you to feel comfortable to make a vote, just to make you think and try and direct your searching. So, with most of you not from Wales, like myself, here we go. I am in fact from West London. This is my home away from home. I work at a large trust, London Northwest. It's three sites due to mergers. I work in Southall, which has a pretty ethnic part of town and very rich pickings for radiologists. We see all kinds of pathology, and we are all, at least some of the time, very general radiologists. Plain film reading remains a very important part of my workload, partly through choice, and partly because if someone has to do it, it might as well be someone who really cares about doing the job well. Now, it wasn't always like that. I started out with a certain amount of fear and trepidation reporting plain films when I came to this place. Just massive piles were put in front of me. I'd spent so much time in advanced training, as a number of you guys will do, that I had a bit lost my confidence. I'd spent so much time doing cross-sectional CT and MRI that plain films had just sort of withered into the background. So today I want to bring you all up to speed a little bit and to show you some cases that we can all grow a bit our confidence. I grew my confidence with the support of my colleagues, But I still, and I feel now that I must have read more chest x-rays than just about anybody in the country. But I still get colleagues to go through tricky cases with me. So let's start with the basics. Try and stick to a system when looking at each film. Check all of the chest. And I don't know which system you've been trained to use, the airways, breathing, circulation, disability, which is the bones and so forth, exposure, or central to peripheral, which is what I tend to use, the heart, move out to the hilar, to the lungs, to the bones, to the outside of the patient. Where is it before what is it? When you're looking at a chest and you find that thing that you want to talk about, try and place it somewhere. Which part of the chest does that sit in before you try and narrow down your differential as to what the cause of that opacity may be. Always run your eyes over the check areas. This is where most misses in the chest x-ray reporting lie. We're going to go over quite a few check areas through this talk. And this is key, satisfaction of search. You know how when you see a chest x-ray and it's obviously got a right middle lobe pneumonia and you're desperate to talk about that, you kind of forget about everything else. This is where it's really important to find the other pathology that everyone else is going to miss. This is where you are the clinical radiologist, where you are looking for what other people, the subtle changes that the ED doctor is going to miss. Now, the ED doctor will miss an awful lot more than you could possibly comprehend, the A&E doctor. But what we want you to do is to remember that you're radiologists. There's no excuse for missing the bits that are there that you just haven't looked at. Satisfaction of search. Make sure you've examined the whole film, not just the obvious bit. Get a second opinion if you're unsure. Show the case out. Hold them back. The cases that you're really, I want to report this, I know it's tough, I know there's some learning in here, I'm going to get someone else to help me. And that's how you grow your practice, not by just going through all the normals. Leave those for the allied health professionals, or whatever they're called, the radiographer reporters. They'll pick through all the normal ones. We need to be doing the ones that our clinical acumen, our ability to put a physicianly head to the image makes all the difference. Get a second opinion, don't avoid the difficult cases. And then when you do put a report out on a case that you're not sure about, but you really want to know the answer to, don't forget to follow it up. Find the answer when they get their CT, or find the outcome of the MDT meeting that case may go to, or any further imaging that may help you get an answer to what was actually going on in that chest. And get lots of practice. I talk about showing x-rays to colleagues. The sign of a healthy group of radiologists is one where you can comfortably ask each other to look at difficult cases without fear of being judged. Some of this is just about forming healthy radiology habits. Maybe it's a Kiwi thing, but I get a kick out of taking a mysterious case and sharing it with my colleagues and seeing if we reach the same conclusion or not. So take those cases out, share them around, learn from them, follow them up, and you'll gradually build up quite a repertoire of experience. So let's look at the first case for a bit of a warm-up. Here's the link again for those of you who, I don't think anyone's arrived late, but if you didn't get it, here's the link. This is a 64-year-old man who's asymptomatic. He's turned up with all the clinical information on all of these cases is as we were given it, and usually it's only a couple of words. In this case, raised ESR, asymptomatic. Okay, so take a look and tell me what you think is going on. Does he have, and I'm not going to put the question to your phones just yet till you've had a decent look, is the heart enlarged? Is there a pericardial effusion? Is the patient in heart failure? All of the above? Or you're not sure? Let's do a CT. How's the resolution for that in the back of the room? Do we need the lights down? Can you see that okay? It's all right. Turn the lights down a bit. Can we have the lights down to make the images any darker, brighter. That's it. So I just have to remember to come back and show you the voting. Sorry, this is the fiddle. So the heart is enlarged 24%, pericardial effusion 60%, heart failure a few, all of the above a few of you are not sure and you're going to do a CT. Let me just slideshow, that's what I need to do. This is the flicking. So this case is all about this big heart. Now I know it's an AP film and I've just given you the answer, haven't I? It's okay in this situation to look at the AP because the heart is so big. The cardiac silhouette here is so enlarged that even if it was even as an AP, you can tell that this is grossly abnormal. The things to note here are that the pedicle is reasonably narrow, that while there is a mild distension of the upper lobe vessels, there's no frank cardiac failure here for a heart of this size. And more importantly, with your physician knee heads on, we've told you that the patient's asymptomatic and he's come in with a raised ESR. So this patient is not going to be in the crashing heart failure that he should be with a heart of that size if that was all pump failure. So if we come back to the CT, we can see how much of this effusion is posterior and how little of it is anterior and accessible to the echo text. So it may be in A&E, if they think they're being clever and put an ultrasound probe on the front, they'll say there's no pericardial effusion or very little. There must be something else going on, and they get a CT. There is a large volume of fluid around this heart. You need more than 50 mils for it to be seen as a pericardial effusion. There's probably several hundred here. Now this patient is asymptomatic because this is not a malignant effusion. Malignant effusions, where you'll see enhancement, nodularity, thickening of the pericardium, have a 25% death rate or fatality rate in the first month after detection. So they don't usually walk in like this. The AP-PA problem is one that we are increasingly coming across, as a number of our overnight chest x-rays are done by radiographers without enough support to move patients off their trolleys. It will magnify the heart and mediastinal structures as these are closer to the source and further away from the x-ray plate. And as the beam diverges, the shadow cast is less a true reflection of the heart size. In this case, the heart being so big, the projection doesn't matter. And it doesn't hide the story the patient is trying to tell us. And you need to bear that in mind when you're looking at an AP film. Don't just dismiss it. Sometimes there is sufficient information on that exam for you to still say that the mediastinum really is widened or the heart really is big, even allowing for that projection. Think about the clinical history and that end of the bed look at the patient as to why that patient has had that image. Okay, so moving on. In this case, the next question, we have a 47-year-old woman. What is the abnormality? Have a look at the image, and I'll get you to cast your vote in just a moment. We are looking to see whether the abnormality is the right hilum, the chest wall, the patient is lying on something, it's in the left lower lobe, or you're not sure. Let's do a CT. Now remember, you can vote more than one thing too, so you don't have to just choose one box. So that's not quite what I meant to do. That's what I meant to do. Sorry, that I'm going to have just slight issues. Yeah, well done with getting these two systems to work. We'll get there in the end. So this is another of your warm-up cases. And you're certainly right to do a CT in this case. So you're allowed more than one option. You can see where we're going on this, can't you? Just come back to my... So this is a chest wall mass, just to point that out. So this case demonstrates a number of abnormalities, and this is where satisfaction of search comes into play too. The obvious abnormality is the massive right breast cancer, foul and fungating. The more subtle finding is the left lower lobe collapse. So well done to the 5.7% of you that got that right. Okay, so we have lost the descending aortic silhouette, and we have lost the hemidiaphragm medially. So there is definite left lower lobe collapse as well as this large mass, and you could argue that there might be something at the right hilum. It wouldn't be surprising if this woman had significant metastatic disease. So here is the CT just to show this dreadful tumour, heartbreaking for everybody that was involved in the care of this woman who just did not want to present to hospital. So a chest wall mass is easy when it is this big. I just wanted to show you this just to remind you to think about shadows on the chest aren't always in the chest. And sometimes moles on the back, very well-defined large moles you'll see looking like a lung nodule. And obviously tumours in the chest wall we may also pick up. It's not often we see them this big. So now you're all warmed up. Let's just refresh ourselves with normal. And we do need to spend just a little bit of time looking at the normal chest x-ray. Now I filched this from Radiology Assistant. It's a really nice radiograph. I hope you can see all those lines here. So we're just going to go through these now. I start from the inside and work outside. I check that we've got major airways and that we can see them. I check that I can see this key structure, really key structure, the aortic knuckle and the descending aortic silhouette. I look at the hilar and check that I can see the upper lobe and lower lobe vessels forming the hilar point. So this clear angle between the upper and lower lobe vessels. If there's anything blurring that, then there's something around the hilar. The azigoesophageal line with the blue arrow on it will be pushed by a hiatus hernia or any enlargement of the distal esophagus. We don't always see it terribly well, but the more I look for it, the more I see it. A lot of these structures, it's a matter of looking and you will see. Remember that the pulmonary arteries come in above the pulmonary veins. The pulmonary veins are more horizontal as they enter the atria. The paraspinal line you should always check, particularly in patients with trauma, for any evidence of bleeding or hemorrhage from a fracture. It may be the only sign you get. And in my part of town, this is key for finding TB discitis. I wanted to talk also just about the silhouette sign, and I've nicked this again from Radiology Assistant because they do such beautiful cartoons. A number of you probably already know what the silhouette sign is, but let's just recap. This is the loss of the normal air soft tissue interface when air cells become filled with a density similar to the structure that they abut. So the air cells being the lung tissue. So if there is consolidation in the left anterior chest, in the lingular region, so that's the most anterior part of the left lung, sits at the front of the chest is the left upper lobe inferior part, the lingular. If that gets fluid or opacification within the lungs, the air cells, you will lose that left heart border, which is the heart, as we know, sits right close to the front of the chest wall. The left upper lobe lingular segment sits against it. Opacify the lingular, you will lose that left heart border. On the other hand, if you opacify the lower lobe, which you think of as being the most inferior part of the chest because it's the lower lobe, sits a bit more posterior. The majority of it is behind the heart, and you may still have a completely preserved left heart border with opacification of the left lower lobe. Now, when you're doing your fancy CT abdomens and all the rest of it in very sick patients, and we see this a lot, notice how often they have opacification in the lower lobes that you may not see on a chest x-ray at first glance. But when you go back and look at that chest x-ray, you may well see that there is subtle change in the left hemidiaphragm, loss of this medial left hemidiaphragm, and the beginning of opacification behind the heart. And it's the loss of that descending aortic silhouette and the medial hemidiaphragm that may give you the clues. The more you look, the more you see. So this applies to all structures that interface with the lung normally, and this is how we can detect where in the chest the pathology is most likely to lie. So where is it before what is it? Now this is just a normal 19-year-old girl's chest that I just pulled off the pile. Just appreciate the lines for a moment that we've just looked at with labels all over them. See that you can see all of them on this chest x-ray. The addition of breast shadows, be aware that they do cross the chest and they will add a little density to the lower zones bilaterally, but they should be relatively symmetric in the patient who has both breasts. The age of the patient is important. Now I've said this is a 19-year-old. A young person may have very big lung volumes and they may flatten off their hemidiaphragms but have no obstructive change. So unless they're telling you the patient has asthma, if the diaphragms are quite flat in a young patient with great big lung volumes, it's just simply that they can take really big breaths. And you'll see this particularly in young men who can take, some of them can take stonking breaths. It doesn't mean that they've got COPD. In an older patient of 60 or over 50 even, particularly with a smoking history, if you see that flattening off the hemidiaphragms and the increased lung volumes, then you can start talking about air trapping and recommend that it's correlated with pulmonary function testing to exclude obstructive airways disease. Don't also forget to appreciate pectus deformity. Now I haven't included a pectus. A pectus is when the front of the chest is stoved in. So when the front of your sternum is close to your spine at the back, the posterior ribs will be much more horizontal, and as the ribs dive towards the pectus anteriorly, you will get a more vertical anterior rib descent. That will explain why in a pectus deformity you blur the right heart border. So if you see blurring of the right heart border and there's no question of infection, think pectus. So in this normal chest, we should be able to count 5 anterior rib ends or about 8 posterior ribs to ensure that the patient has taken an adequate inspiration. If they've taken an adequate inspiration, then the rest should be fairly straightforward. We should have enough there to be able to make a solid report. So with normal anatomy and no pathology, you can give this your normal chest x-ray report. Over time, your eyes will become very quick at filtering normal from abnormal. Now, for those of you that would like, please take photos of any of these slides. This is my normal chest x-ray report. It's been plagiarized. I mean, it looks so pathetic, doesn't it? It's just very small. It's only 4 lines. But that's what I've condensed down to that I feel comfortable reporting on every normal chest. And I just say insert normal, and that pops up. What I do is put my doctorly hat on and look at the clinical question. So if they've said chest pain, query pneumothorax, 19-year-old female, I will say insert normal, no pneumothorax. Answer the clinical question. If they're saying severe epigastric pain, query subdiaphragmatic air, I will say insert normal, no subdiaphragmatic air if there is no subdiaphragmatic air. So answer the clinical question. And I think this is particularly important when we are reporting x-rays for our GPs. So when the GPs come, they don't have access to our images. They don't ever get to double read what we are seeing. answer the clinical question. Give them the courtesy of telling them that you've acknowledged what their clinical question is. Be a clinical radiologist. The only way to defeat AI and the reporting allied professionals is to use your medical head. Turn it into a clinical report. The most difficult word of all in radiology can be normal. Some people rarely use it. I use it often, as for me to be told that I'm normal in any context is hugely relieving, and so I believe it will be for the patient receiving my report. Right, see if we can get the voting right this time. This is an 87-year-old woman with an unwitnessed fall. So have a look at the exam. So this is about thinking about the silhouettes and lines that we've just been reviewing. What is the abnormality here? Is it the left hilum, the aorta, the main pulmonary artery, or the thyroid? Give me a moment. Hopefully this will... There we go, good. So we can see rough percentages here. Let me just go back to show those of you that need to see the exam again. Okay, so this is quite straightforward and well done. This is a dilated aorta. Now she's presented with a fall, so I'm putting my clinical hat on. This comes to the, let me just come back to the big picture. So this comes to our radiology lung meeting as, oh my God, her aorta's enormous, what shall we do? And the answer is, look back at the old films. So we look back at the old films and see that a year ago she had that CT scan that showed this hugely dilated aorta. So as we follow this really important structure, the aortic knuckle around, we can follow it down. It has a linearity that is all contiguous. We can see that this is dilated aorta. Okay, so when the lung team came and said, should we not call the vascular surgeons, it was easy to flick back to the old studies and say, look, they've been watching this for a while. No one's done anything about it before. They're not going to do anything about it now. And you failed to tell me that she's actually got severe dementia, which is written on one of the earlier clinical information tabs. Do look back at the old films. Often half of the answers are in the pile. And it's amazing how often you end up knowing more about the patient than the team that are looking after them, just simply by reviewing the clinical information on the previous imaging. Right, next trick. Check areas. So this is how my head does it. This is what happens if you let me loose with the graphics. The yellow bits are the check, check, and recheck areas. These are the hilar points that I was talking about. Make sure you can see this nice angle at the division of the upper and lower lobe vessels. If you can't see them, ask yourself why not. And you can come back to talking about exposure and poor inspiratory effort and all the rest of it. But look for it. Look for the airways, look for this important red structure, the aortic knuckle and descending aorta. Check that you can see both sides of the heart. But these are the key areas. The lung apices, below the right hemidiaphragm, the big one, where all the gold is, in the left lower lobe behind the heart. So many of our misses, so many of our undercalls are in this area. The left hemidiaphragm, particularly free gas under the diaphragm, but sometimes there are little mysteries hidden down here, which if we have time we may see one of. So check that all of these areas are normal before you issue your normal report. Right, that's enough about the normal, so crack through some cases now. This is another case then. A 74-year-old man, recent travel to the Middle East with a cough. So what I want you to tell me is whether he has right upper lobe TB, I'm from that part of town and he's been to the Middle East, right upper lobe bacterial pneumonia, a right upper lobe mass, right upper lobe hemorrhage, or right upper lobe consolidation, do a 4 to 6 week chest x-ray to check that it resolves post-antibiotics. So if I get this right, no, didn't like that, sorry. There you go, you can vote now. That's fair. So, as I say, I'm giving you cases that someone may not have got right. Someone called this a right upper lobe mass, and I managed to stop this patient going to CT. And we sent him, we just checked with the clinicians that they were happy that this was just consolidation, that he was behaving like infection. Can you see the air bronchograms through here? It is a mass-like opacification, and no one would really criticize you if you did CT this, and it's really down to the clinicians who are looking after the patient to come and say, well, actually, he's got a temperature of 38. Sorry, we forgot to tell you that, which is usually what they do when they come and question why you've, well, actually that's not true. They usually put them through the CT scanner and then say, oh yeah, we forgot to tell you he had a temperature. So what fills the air cells? This is the question when you come across any opacity in the chest. And I just want to give you my quick surgical sieve, if you like, of the possibilities here that you can, this is what I use, it stood me in really good stead over the years. It's the most basic of sieves. Okay, so pus, could the air cells be filled with pus? Could this be infection? If it's infective, is it bacterial, viral, or TB? I mean, I come from the TB capital of the UK, so TB goes on every slide, sorry. Could it be blood? Is there any history of trauma? Is this a young patient who has possibility of Goodpaster's syndrome? Is there the possibility of vasculitis? And don't forget vasculitis when there's more than one opacification and it may cavitate. Rarely idiopathic hemosiderosis. Fluid. Could the opacification be due to fluid? Are the air cells filled with edema? So that's probably our most common alternative, isn't it? So pus versus fluid. If it's not straight cardiac failure, could it be aspiration? Don't forget food, particularly in our aging population. I mean, in my time of working over the last 20 years, the average older patient has gone from about 80, 81 to about 90 to 95. I mean, we've got such a much older population than we had even 10 years ago, and there is much more aspiration going on out there. Occasionally it'll be blood aspirated in the trauma setting. And then cells, so pus, blood, fluid, and cells. And by cells, I primarily mean cancer. So if you just think of that sieve as you run through any opacity in the chest, you'll cover most things. So this was just a simple pneumonia, but it could have been focal hemorrhage in the right setting. It had the right density. It could have been a mass if he didn't have the symptoms of infection. It didn't really look like edema, and you'd have needed a slightly different history. So we thought this was infection. We gave him a request for a repeat chest x-ray 4 to 6 weeks after he had had his antibiotics, and this completely resolved. Okay, so just one more report for you here. This is how I would report this exam. So a report for chest infection. There is consolidation in the right upper lobe, you could see that with air bronchograms. Okay, so I've justified why I think that's consolidation. The appearances are in keeping with a right upper lobe pneumonia in this clinical context. Elsewhere, the lungs and pleural spaces are clear, and then the normals, cardiac, mediastinal, and hilar contours are normal. Right upper lobe pneumonia is my conclusion. The important bit is what goes next. A repeat exam following antibiotic treatment is advised to document resolution. Now, this is not everybody with pneumonia. It's those who are over 50, who have a risk of malignancy, and those who are smokers particularly. All right? So I always put this caveat on the bottom, the usual post-treatment for a repeat chest x-ray is 4 to 6 weeks, providing there is no interval deterioration. if the patient has had a previous recent exam, and you'll see this in the hospital setting a lot, they may have been through the CT scanner just recently and then suddenly they get a big opacity and it sort of looks a bit mass-like. If they had a normal CT or a normal chest x-ray a few weeks ago, this is not going to be cancer, is it? They don't need a follow-up. This is going to be the hospital-acquired pneumonia. So do bear in mind what else is in the film packet. Okay. 54-year-old male, left-sided chest pain. The question here is, does this patient have left upper lobe collapse, left lower lobe collapse, a left hilar mass, left upper lobe consolidation, left lower lobe consolidation, or you're not sure? Let's do a CT. So have a look before I push you to the vote. Make your decision. Remember what we've been talking about, all those lines and structures. What can you see and what can't you see? And how will that help you? Where is it before what is it? So vote now. Well, you're nice and quick, well done. Okay, so 78 votes have been cast, 81 from 57 participants. So some of you have chosen more than one thing, which is fine. And a good third of you have chosen the correct answer, which is left upper lobe collapse. So let's just go through this and why this is a left upper, because this is a really important film, I think. And we don't see it that often, but when we see it, we have to get it right. So this is a veiling density, a vague density over the upper left chest. That's the first clue. The second is that we've got a very hyperinflated lower lobe, because this is the left upper lobe gone, collapsed. Here we have a crescent of air, the Luftsichel sign, Luft meaning air, Sichel meaning sickle, a sickle-like lucency between the collapsed upper lobe and the mediastinal structures at the top. This is the hyperinflated lower lobe against the collapsed upper lobe. You can also see this very horizontal left main bronchus. See how the bronchus has been pulled up by the collapse. So as part of your check, when you're looking through the airways, this is abnormal. Okay, you can see the left lower lobe vessels beautifully. There's nothing going on in the left lower lobe down here. You can see behind the heart, you can see the hemidiaphragm, you can see the aortic knuckle and the descending aorta. All of these structures are abutted by the left lower lobe. So you will not, there's nothing going on in the left lower lobe. This is the classic appearance, learn it, keep it, hold it, of left upper lobe collapse. What about this one? So this is a 53-year-old with cough and chest pain. The question asked of us was, did the patient have an aortic dissection? So I'd like you to vote as to whether or not you think this patient has an aortic dissection, yes or no. Enough time to have a look. Fabulous. Anyone else? Go on, I've just given you the answer. 61. Are there 61 of you in the room? But as if there should be a few more than that. So that is the correct answer. And let's just have a wee look why. Now, I hope this is all now really obvious to you. Look at the aortic knuckle and the descending aorta. There is nothing going on here. This aorta is pristine. What have we lost? So if we look down our main airway structures and bang into this thing, if we look for our hilar point, so we can see the vessels on the right side, this beautifully normal right lung, all the silhouettes are preserved. On this side, where's the main pulmonary artery? We can see the aorta, and then we've got opacification really overlying the hilum, haven't we? So there's something going on in the hilar territory. What should we do next? Exactly. So this is a really aggressive, unpleasant, life-threatening tumour encasing the main pulmonary artery. So we've lost that main pulmonary artery silhouette because there is a small cell tumour wrapping around this. This woman only lasted a bunch of months. This is cancer. The correct assessment of that chest x-ray would have meant this patient would have had a staging CT chest and abdomen and not a thoracic aortogram. Okay, so that's the difference that you make by looking at that film, and when they say, we think she's got dissection, she's got a widened mediastinum, let's do an aortogram. You look at it and go, hang on, no, her aorta is absolutely pristine. I'm confident this is not a dissecting aorta. This is a pulmonary mass. Okay, sticking with the same theme, what about this one? We have an 81-year-old woman with leg swelling and a murmur. The question is, does she have cardiomegaly? So take a look at the picture. I want you to tell me what is the most likely diagnosis. Is this a cavitating pneumonia, a cavitating pulmonary infarct, a cavitating malignancy, a Morgani hernia, or you've no idea? Let's go straight to CT. I mean, that's quite a list, isn't it? All of these things can cavitate. Malignancies can cavitate. Pulmonary infarcts can really cavitate. They do. They can turn into abscesses with dead lung. Pneumonias, as we know, this is one of the things we need to be looking for, the cavitating pneumonia, to think about alternative organisms such as Klebsiella and Staphylococcus. I'm just going to get you to vote now if my mouse will behave. Come on, mouse. Sorry. Come on, mouse. There we go. What do you think? Good, 62 votes. I think that's probably most of the people who are voting. I think this is a very fair spread, and that's why we're here today. We're to look at what we can talk about on this case to tell you why it's not a cavitating pneumonia, why it's not a pulmonary infarct, why it's not a cavitating malignancy, and why it is a Morgani hernia. And you'd be perfectly fine to go straight to CT, because that's exactly what one of my colleagues decided was a good idea. You're totally, I mean, these are very dramatic looking images, and they will often be CT'd. So let me just show you the CT. So just a single slice. I wasn't brave enough to put videos in this talk. It's hard enough with the voting. This is the typical location of a Morgani hernia. It's an anterior diaphragmatic defect, which you can see. You can also see on this image just that it's abutting the heart, it's abutting the mediastinum. There is colon protruding through this defect, that's what's giving you the cavitation effect. This will often get a CT because it looks so dramatic. Remember the more common Bokdilek hernia, Bokdilek at the back, and Morganis are in the middle or anterior. They're really anterior rather than middle, but it's to remind you that they're not at the back like a Bokdilek. They're much less dramatic, the bocdylics. They tend to have fat or kidney in them. They tend not to have bowel in them, and therefore they tend to sit across the centre of the hemidiaphragms, and they're more easily picked up as a diaphragmatic eventration or a bocdylic. So why do we think this is a Morgani and not any of those other things? So the things to notice on this is a female. So she has breast shadows, and what you mustn't mistake is that the inferior edge of the breast is not the inferior edge of the mass. Okay, so we have a preserved hemidiaphragm. We have lost our right heart border. So this mass is abutting the right heart border. It has a very clear upper surface. If this was a cavitating infarct, so an abscess in the lung, this would not look so crisp and clean. If this was a cavitating pulmonary malignancy, it would really not look so sharply delineated. If this was a cavitating pneumonia, I would not have expected her to turn up with leg swelling, murmur, query cardiomegaly. You have to think as a clinician. That immediately makes everything else much less likely. She is much less likely to have a cavitating infarct if she's just pitching up with a query cardiomegaly clinical question. Does that make sense? So look at the whole film. Study everything around it, and where is it before what is it? Think like a doctor. If this was the true history, it is very unlikely that this is malignancy. That's the first thing you need to think of. What about this one? This is a 64-year-old who has chest pain. What is the pathology? Is this cancer, heart failure, aortic dissection, or a malpositioned pacing wire? Just get there's my voting screen gone. Here we go. So vote now. It's a hard one, isn't it? Do you want to see the picture again? Okay, so 52 of you have voted. Some of you are too shy. You're all herding to the malpositioned pacemaker. Some of you think it's a dissection, some of you think it's a left upper lobe cancer, not many of you think it's heart failure, and and some of you think it's a right upper lobe cancer. Let's have a wee look. So this is a serious miss. This is the sort of case that I really want you to look at, and this is the satisfaction of search. It's a really busy image, but please notice this significant mass overlaid by the aorta. Can you see that? Is it just not projecting so well, perhaps? Can you see that there is a pulmonary mass? Let's just go back one. This is part of that check area rationale, why we have to look and look again. Here's the tumour. This was a confirmed left upper lobe malignancy. Now this is a busy film, there's a lot going on. You just need to go through your check areas. Okay, what about this one? 44-year-old man turns up with retrosternal chest pain since noon. He turns up in the afternoon. It hurts. Doc, what's wrong? Where is the abnormality is the question. Is it in the posterior mediastinum, the middle mediastinum, the anterior mediastinum, or the chest wall, or you're not sure and you'll do a CT? Okay. So this is a posterior mediastinal mass. We're talking about this shadow at the top here. So it will get a CT. So those of you that felt it needed a CT and you weren't sure, absolutely fine. That's what he needed anyway. They almost always get a CT scan. The retrosternal chest pain was a red herring. We often have that. I hope you all found that mass sitting at the top here. What makes this more likely posterior than anterior is that we can see all of the anterior structures. We can see the aortic knuckle, we can see the descending aorta, we can see the hilar vessels, we can see the heart. We can see the paratracheal stripe adjacent to the, on the left. So that makes it really much more likely to be posterior mediastinal. So this is a posterior mediastinal mass in an adult. This is most commonly a neurogenic tumour. They almost always get an MRI scan, and in this case the way you tell that this is a schwannoma is that the attenuation on the CT scan is lower than the muscle. That's the take-home message for your exams. Lower attenuation in the muscle makes this a neurogenic tumour, most likely a schwannoma. Just quickly, for those of you that do need lists for exams, posterior mediastinal masses. Try and remember that children are more sympathetic than adults, therefore children's tumours are sympathetic, therefore they get the gangliomas and the ganglioneuroblastoma and the neuroblastoma. So adults, which are the ones we tend to see these in much more commonly, unless we're working in a paediatric centre, much more commonly schwannomas and neurofibromas. Of the neurogenic tumours, about 30% are malignant. The posterior mediastinal mass also can be due to a whole list of other things. I won't go through each of these, and again, it will depend on the location. A Bochdolek would be posterior and inferior. Trauma, always think about the traumatic cause for paraspinal. We talked about that before, the fracture with the paraspinal widening secondary to hematoma. Foregut cysts and so forth, they'll almost always get a CT scan. What about this case? This is a 58-year-old man who is unwell. Now this is a very important slide, and I thought we'd look at this one together because this is the sort of case that you look at and you go, oh God, move on to the next. But actually this is the case that needs to be reported urgently. This is the case where you need to get some help if you're not sure what the answer is. And this is the case that we really do need to act on. The clinical question was infection or pneumothorax. So there's a lot going on in this film, and I want you to just have a look around, satisfaction of search. Can we narrow down where is it before what is it? And then once we've narrowed down to where the pathology is, can we decide what it is? So one clue here is the normality of the contralateral lung. So we've got a very normal looking right lobe. We've got clean lines, all of them preserved, and we can see all of the parenchyma, and there's no pleural fluid. So we're confined to the left lung and the mediastinum. So pus, blood, fluid or cells. So no history of coughing up lots of blood. We're not aware that there's been any trauma, so blood is probably less likely, and we don't see any rib fractures. Pus, could this be infection? Anyone think this could be infection? Hands up if you think infection. Come on, be brave. So you all think it's something else. A couple of you might go for infection. Do you think it's fluid? Is this all fluid? Fluid, anybody? Few for fluid. There's definitely a pleural effusion. There's a meniscus here. Is it all fluid? So blood, no. Pus, maybe. Fluid, yes, there's fluid. Cells, anyone think this is tumour? So you're all shaking your heads. So you would just, crack on and do a CT? So the answer here is that it is difficult, but the clues are here, and the big clue is that there is mediastinal widening, and our old friend the aorta, where's it gone? Where's the aortic knuckle and the descending aorta? So they're completely gone. We've got pleural fluid. This is a well-centered film. It's well exposed, but the trachea is pushed. It's moved to the other side. Does fluid do that? a pleural effusion. A pleural effusion will tend to collapse the lung underneath it, subpulmonic atelectasis. It will tend to reduce the volume of the hemithorax, or the lung volume of the hemithorax, and occupy the remaining space with fluid. It doesn't tend to push like this, and it doesn't obliterate mediastinal structures like this. The big clue here is this mass effect. And if you look at the right azygos region, this also looks a little bit widened. If he had infection, he would be gravely ill. If it had got to be this bad, I would expect him to be on oxygen and, to really be very, very sick. We did what we normally try to do in these cases before we put them to the CT scanner, is to get rid of everything that's acute. So try and drain the fluid off before you put them through CT. And we can now see that there is a bit of volume loss in this lower lobe. There is some atelectasis, there is some collapse, but we've still got this massively widened mediastinum with mediastinal push. So this is not just fluid, and this is not just infection. Also note that the carina is not particularly lifted. The carina maintains its normal anatomical location. So now, hands up for infection, hands up for a mediastinal mass. That's the way, good, all right. And this is what's important. This is a really nasty tumour, and it's a very big tumour. It's climbing out through the chest wall. This is a 58-year-old man. He had, on further questioning, night sweats for 4 weeks. And so it was a question of, was this a lymphoma, confluent nodal mass, versus a malignant thymic tumour? He had, in fact, had a T-cell lymphoblastic lymphoma. So let's quickly run through the anterior mediastinal masses, the 4 Ts. You can have a goiter coming down into the anterior mediastinum. You can have terrible lymphoma, just like this one. Hodgkin's disease in younger people, older people, more commonly non-Hodgkin's lymphoma. Thymus. A thymoma, the benign thymic tumour, is the most common cause of an anterior mediastinal mass. But you may also have malignant thymic tumours. And teratoma, or germ cell tumours. 75% will be mature and benign. But don't forget teratomas. I've seen a number of malignant germ cell tumours too in my time. Okay, next case. 33-year-old central chest pain, discharged home 4 hours later. What do we think? 33-year-old male. The question I'm going to ask you is the mediastinum normal? Yes, this is all heart failure and vascular congestion, or no, this is a more serious widening of the mediastinum. I just get my mouse to, there we go. I can see a trend here. This case, personally, I find really upsetting. I got very upset about this case. I sometimes cry over cases, it's terrible. I had one the other day, 29-year-old, horrendous. This one I cried about. This is a 33-year-old who got sent home. I got to report this at 8:20 the next morning. I called the emergency department and said, this chest x-ray is very abnormal. The mediastinum is widened. I don't quite know what's going on. Let's do a CT. I was the last option. I thought it might have been a dissection. It could have been, with that chest pain, a myocarditis or another cause. He could have dissected into his pericardium. I don't know, he died at 2 a.m. This is what we go through that pile of plain films and pull out. This is what we are looking for amongst all of those chest x-rays. It's the ones where, if he had turned up in office hours, could we have done something? Could we have got the helicopter in? Could he have gone to the Brompton or the Harefield? Could he have had his dissection repaired? Sorry to be so sober, but sometimes it really is important, and it's really important that we put 33-year-old chest pain and abnormal chest together and come up with this ain't right. So I don't know the answer. This is what he looked like 4 years beforehand. He had a normal chest x-ray. Moving on then, this is a 55-year-old. You'll notice that most of my cases are people around their 50s. Being around 50 myself, I find it a very dangerous time of life. Most of these are young people with very serious illnesses. When I say young, not ancient. All right, so this is another 55-year-old. She's short of breath. What is the diagnosis? And the question is, does she have cardiac failure? Does she have fluid overload? Has she had a drug reaction? Is it renal failure or is it infection? And I'd like you to vote. I'm going to have to put some pace on here, I think. So, chaps, I'll get you to... It's a fairly straightforward film, isn't it? She's 55. She's got all of this going on. Is it failure? Is it fluid overload? Or is it any of... Come on, vote, come on. Come on. Lost my little hand. Come on. Okay, sorry. It's just because I said I needed to get some pace on. Okay, I like your thinking. Okay, that's totally fair. So lots of you have voted and you're going fluid overload and drug reaction or possibly renal failure or maybe infection, but probably not cardiac failure. And this is why I want to show you this case. So this, if you look at this heart, it doesn't look enlarged, does it? Now, the thing to remember about heart failure is that when the pump starts to fail, the heart will hypertrophy. The left ventricle, if it's left-sided pump failure, the heart will hypertrophy before it dilates. So you may catch them at their first phase of heart failure before the heart is enlarged. Or it may be a chamber you're not thinking about. It may not be left ventricular failure. So the answer here is she is, in fact, in cardiac failure. So she has pulmonary venous hypertension. There is distension of the upper lobe vessels, but they're still reasonably crisp. She's got interlobular septal thickening on the sides. She's got curly B lines, as we call them, and she's overflowed into her interstitium. You'd also be right if you'd noted that there was probably some infection going on. We've lost the medial hemidiaphragm here, and we've lost the descending aortic silhouette. So well done to those of you that picked up that she also had some infection. This is what she looked like 2 months after her hospital admission, and she's still got those interseptal lines. It's the most beautiful picture of interseptal or curly B lines I've ever seen. So she's got hyperinflated lungs. She's a marathon smoker. She's still got a normal heart size 2 months later. What's going on? If you look very closely at this heart, the heart size is normal, but there is, in fact, additional density underneath the hilum here. This is where the left atrium sits. And you may talk yourself into saying that left bronchus is a little bit lifted. It's really much easier to say that with conviction when you've seen the CT scan. So you can see how the cardiac diameter is not increased, but the left atrium is massively enlarged. This is when she was in acute failure. So she has a mitral valve stenosis. The heart is struggling to empty from the left atrium into the left ventricle. That's why her left ventricle is normal. That's why her heart's not so enlarged. But she's an overt cardiac failure. This is another really important slide. I just want you to learn it. Practice putting the chambers of the heart on x-rays until you've got the hang of it. Left atrium, left atrial appendage, right atrium giving us that right cardiac silhouette. Left ventricle giving us the left cardiac silhouette in part, and the right ventricle lying anteriorly. I love this cartoon view of what we're looking at. This is again from Radiology Assistant. This beautifully demonstrates all the features that we're looking for in heart failure, and I really want you to be comfortable when you're looking at the grotty chest. So this is about the grotty chest. This is the x-ray you don't really want to report because it just looks like a load of rubbish. You just need to dissect these details out and you'll have an answer. Okay, so look for upper lobe diversion. Look for the interceptor lines, which you won't see that often. Look for the pulmonary edema. Look for the widening of the heart size, the increase in the azygous vein, more than 10 millimeters, it's too much, and the widening of the vascular pedicle. So what about this case then? Here is a lady of 34. She's short of breath and wheezy. She has all the signs of cardiac failure, but again, she doesn't have the enlarged heart. The primary abnormality here then is either just what the case we've talked about, a stenosis, a left atrial enlargement, but we can't see any evidence of that in here. There is no increased density under this, that the carina is in the right position. The primary abnormality here is not pump failure. So on our other list, we talked about drug reactions and fluid overload. This is when this lady had her first dose of meropenem and then got this chest x-ray. So this is that case that we're dreading. This is the cardiac failure look in a patient who has had an immediate reaction to an antibiotic. This is when the glycocalyx strips off the endothelium of the blood vessels and the vessels leak, and they'll leak stupendously. They will just suddenly go from normal to massively overloaded with pulmonary edema. She's overflowed from the interstitium into the alveolar air spaces. We've lost the venular clarity, so she's leaking through the veins. The veins have lost their distinction against the air cells, and we've now got fluid in the alveoli and in the pleural spaces. So heart failure, if the pump fails, what happens next? If the blood doesn't leave the heart so well, you reduce your cardiac output. If the blood backs up into the heart, if it backs up from the left ventricle into the left atrium, you will get left ventricular hypertrophy first, and then the ventricle will dilate. If it's the atrium will dilate rather than hypertrophy. The blood backs up from the left atrium into the pulmonary veins, the veins draining into the left atrium. The pulmonary veins will begin to distend, so you initially equalization and then pulmonary venous distension, giving you that upper lobe diversion. So that's when it's overcoming gravity and they're filling these upper lobe vessels, you know that the patient is in good going heart failure. The pulmonary veins will start to leak because of raised hydrostatic pressure. The perivenular fluid as the vessels start to leak, you lose your clarity of vessels, and then finally the fluid will start to be taken up by the lymphatics. You look for your peribronchial cuffing at the hilum, thickening of the endon bronchi, and the various other places that you'll see interstitial fluid. You'll get the interstitial reticular look through the lungs, and then it will overflow into the alveoli when the interstitium is overwhelmed, and you'll have alveolar edema. Similarly, with other causes of non-inflammatory edema, don't forget the renal failure, we had that on our list before. Impaired flow of lymphatics, so anyone who has bad malignancy, don't forget lymphangitis, and any cause for reduced osmotic pressure. So the ITU patient who's third spacing everywhere will often have this look. So let's summarize. How am I doing for time?
1 minute.
1 minute, oh my goodness, let's summarize fast then. So be systematic. I haven't talked about tubes and lines, but you must address those all first. Be consistent. Go through your set pattern, whichever it is, central to peripheral, which is what I like to use, or airways, breathing, circulation, and so forth. The tough stuff. Remember who you are and remember why you're here. You are doctors who have a talent for reading film and putting clinical practice to the image that you see. Don't forget to look at old films. Give yourself all the help you can get. We are very bad at heart failure. I hope that quick run through heart failure will allow you to understand the pathophysiology of why the pump fails and why the x-ray looks the way that it does. Is it or isn't it? Make a decision. Don't be afraid of the grotty chest. You can work it out. Get some help until you're confident. Infection, can you find what others miss? Look for the subtle cavitation. Think of Klebsiella and Staphylococcus. Find the multifocality of it. Find the bits that the ordinary clinicians out there are not going to see. Be the voice of the patient for the GP patient. Cancer, find it or else. There are some really tough cases out there. I've shown you some today. It's the cancer cases that are going to get you, so look hard, satisfaction of search. In the trauma cases, look for the subtle injuries. Don't stop looking, keep looking. Even the surgeon can find the obvious. And imaging is the new clinical acumen. So I want you guys to be what you can be. Don't forget the plain film. This is the room full of people waiting outside your department, all of them equally anxious to the 3 that are waiting for a CT scan or an MRI. That room full you can address much more quickly than the colleague of yours who's going to spend all day reporting about 15 or 20 CTs. Remember that, in fact, there are a lot of patients that we're here to serve. Put your clinical hats on when you're looking at the plain films, and don't forget that we can, I'm not going to have time to go through this last case, that we can make a difference. I'd encourage you all to not be afraid of plain films. Don't forget to keep practicing as you go through your training. And once you come out the other side and you're super clever in the art of reading a prostate MRI or whatever it may be, don't forget to come back, find your confidence again, and continue to just report a few plain films every day. Don't let AI take over. Don't let the allied health professionals